Hello, I am Dr. Mirela Cernăianu, and I welcome you to the Wellness Optimizing Warrior MD podcast, the WOW MD podcast. I am not your typical wellness coach, and this is not a typical wellness podcast. Here, I'll discuss educational facts about health, hormones, intimacy, anti-aging, and beauty trends, all very hot topics, to empower you to make great choices when it comes to your health and to your body. I want you to go, wow, I did not know that. Or, wow, this is going to make a great difference for me. Our healthcare system is broken and it needs a revolution. You and I can start one today. I am willing to share my knowledge with the world if you're willing to listen. Let's get started. Hello, listener, and welcome to another episode of the Wellness Optimizing Warrior MD. In this episode, I'd like to approach a topic that is first and foremost quickly becoming an issue with many clients who are using hormone replacement therapy and need to take progesterone. They still have a uterus. They still have the potential to have a period or bleed vaginally when they're on hormones. So how to take progesterone, it's a conversation that happens a lot, and we have a lot of questions. So the reason why I did this podcast episode is because I would like to educate you, the client. And if you're a guy, you probably don't need to listen to this episode at all. But if you're a woman over 40 and you're concerned about hormonal wellness and hormonal balance, and you are taking progesterone, then please listen because you will find out valuable information, okay? Also, as you approach menopause in your 40s, and you will consider whether or not you are willing to have hormone replacement therapy, and you're entering menopause with a uterus that has a disease, that type of information and what kind of progesterone you need to use and the consequences might be very useful to you too. So to have or not to have a period when using hormone replacement therapy after menopause, it's the theme of the podcast. Do we need to bleed? Is it bad if we bleed? Is it bad if we bleed while we take hormones? So this is an important question. And I don't know if it's just me and my personal take on hormone replacement therapy and use of progesterone and the way it's been used by the medical community, but I'm absolutely amazed at the lack of options as far as how to use progesterone for menopause management. And there's an absolute lack of personalization that a lot of patients get from their doctors. So basically, the truth is that you go to the doctor, you get prescribed some form of estrogen, and you're told to take this progesterone every day for the rest of the time that you're going to be on estrogen. And there's no option being discussed about doing cyclic progesterone to mimic your cycle and to allow you to have a period. And I'm not sure why. That's a different topic for another time. But what I'd like to address in today's episode are the pros and cons of having a monthly, regular, predictable, planned and scheduled vaginal bleeding that mimics a natural period when using estrogen replacement therapy and needing progesterone for women that actually have a uterus. And what I'd like to establish from the beginning is that this option of using progesterone a limited amount of days monthly instead of using progesterone daily is not for everyone. This discussion shouldn't apply to patients with different types of pathologic conditions like endometriosis, adenomyosis, severe fibroid uteruses, because for you, if you're one of those patients, having a period was probably a nightmare. And the women who have suffered severe painful periods and clots for many years, who are accompanied by lower abdominal cramping and back pain, this is not something that anyone wants to relive or bring back years after menopause. If anything, these women are looking forward to get the relief of not having a period and possibly the relief that the no longer having estrogen in their bodies gives them from these terrible periods. So even though they suffer in other ways from the loss of hormone, their periods were so bad that some women are extremely gun shy about any type of estrogen replacement because they do not want to bring back any chance that the pathology will wake up from estrogen, and I don't blame them. Now, if you have suffered or are suffering from these gynecological conditions like endometriosis, adenomyosis, which is endometriosis of the uterus, if you have fibroids, if you have required an endometrial ablation when you were younger, if you have had terrible periods throughout your lifetime, especially in perimenopause, then keep in mind you will be limited in how much estrogen you can receive as replacement, because the estrogen can and will flare up your pathology, your condition, and you will likely benefit from taking daily progesterone because it will subside your condition, will allow endometriosis to be kept at bay, will avoid the terrible periods. Again, you've already suffered enough from those terrible periods, so you don't need to continue suffering. So it's important for you to let your doctor know how bad your periods were in your fertile years when you talk hormone replacement therapy, because this is very useful information for your doctor. Now, in these situations, testosterone therapy is amazing. I will dedicate a whole podcast on endometriosis, fibroids, and other types of pathology that's estrogen dominant and how testosterone can help for that. But please stay tuned for that. Right now, what we're talking about is to bleed or not to bleed on hormone replacement therapy. And I'd like to talk about this subject because there's a lot of disconnect and not enough information and clarity of opinion. There's definitely no studies that I'm aware of. If you find any, please shoot me a message and let me know. No studies that are looking at benefits versus side effects and problems with daily progesterone as opposed to cyclic progesterone to balance estrogen. And again, we're talking about women in menopause that are using estrogen replacement therapy and require progesterone to balance that estrogen effect because they still have a uterus. The standard of care of what should be offered and how it should be offered as far as balancing progesterone with estrogen in women who use estrogen after menopause or who need progesterone at perimenopause, that standard of care when we advise women on how to use progesterone either daily or cyclically is literally lacking. It's pretty much all for all. Whoever wants to do something does it. Everybody uses their own personal beliefs and knowledge. So I'm asking, what is the best course of action we, the doctors, should recommend? And what is the best course of action you, the patient, should choose? So the question is, if we take progesterone to balance estrogen, when estrogen is replaced, do we need to take progesterone daily all the time, every day for years on end, as long as we take estrogen? Or should we take progesterone the minimum amount of days that it's required to balance this estrogen growth effect, proliferating effect on the uterus, on the breast, on other tissues? Do we need to take it 10 days a month, 12 days a month, 15 days, or 20 days a month? So first of all, why do we need progesterone? If you really want the answer to that question, I did dedicate 2 podcast episodes to progesterone. Please go back and review those. But I am going to summarize it here very briefly. As long as we produce estrogen, we also need progesterone. The absence or deficiency of progesterone and the overabundance of unbalanced estrogen leads to estrogen dominance, which is the hallmark and accompanies many female organ dysfunction: PCOS, fibroids, ovarian cysts, endometriosis, uterine polyps, heavy and painful periods, irregular periods, etc. We also need progesterone for breast and mental health and many other things. So please consider progesterone after menopause, even if you no longer have a uterus. So let's come back to the topic of discussion for today. To bleed or not to bleed after menopause when using estrogen. Let's talk perception. Most women at menopause and after menopause no longer want to have a period. Having a period is considered annoying, distressing. It's not really desirable by many women. On the other side, there are women who feel better when they have a period. They feel that having a period and shedding their lining regularly cleanses them. And they feel better physically and psychologically when they have a period once a month. There are women who hate having periods because they have other accompanying symptoms like severe headache or mood changes. And for them, having a period is a really major inconvenience. Now, the women who hate periods definitely do not like the fact that they're bleeding, even if the bleeding is planned. And all of them do not like the symptoms that accompany the bleeding: the cramping, the bloating, occasional heavy flow, sometimes clots, the needs to use pads or tampons. All of these are limitations that will impose changes in their lifestyle, including being intimate with their partners, which cannot happen when you're bleeding. There are many women who perceive having a period as natural. They don't mind it. As estrogen rejuvenates their bodies and they feel better, their energy and their mental health improves, there is the realization that the pelvic organs will also be rejuvenating at the same time. And that is a desirable effect. As vaginal dryness disappears, recurrent urinary tract infections are no longer an issue, sexual intimacy becomes pleasurable again. It was painful before. Unfortunately, this rejuvenation effect does apply to the uterine lining and the uterus itself. So women who suffer from mild to moderate uterine pathology like fibroids or endometriosis should be aware of the fact that the possibility of periods returning is very real if the amount of estrogen required to obtain relief in menopause will possibly wake up their existing uterine problem. Let's talk about physician perception. As far as physicians go, there's a significant fear of women bleeding after menopause, especially if they are on hormones. As all physicians who are trained in bioidentical or conventional hormone replacement therapy are aware, usually postmenopausal vaginal bleeding while a woman uses estrogen could be a sign of alarm, could be a sign of something bad, a possible pathology. It's much more likely for our mind, judgment, and problem-solving inclinations to always consider the worst-case scenario, which is the possibility of precancer or cancer type of bleeding versus the possibility that this is purely a breakthrough bleeding from hormonal imbalance. And the truth is, many women go through somewhat necessary workup procedures like an endometrial biopsy or a hysteroscopy that sometimes are unnecessary. Because in 90% or more of these situations, the bleeding is always caused by a hormonal imbalance between the estrogen and the progesterone effect on the uterine lining. And the pre-existent possible newly developed uterine pathology, like endometrial hyperplasia, uterine polyps, smaller fibroids, those are less likely, but they're possible. I say somewhat necessary workup because in the majority of cases, the workup is required always to ensure the physician and the patient both that it is safe to proceed with hormone replacement therapy. So please do not take the fact that I'm telling you 90% of the time is due to hormonal imbalances. Every time there's bleeding, you need to see the doctor and you need to discuss with the doctor why you're bleeding, how you're bleeding. And if you have chosen to bleed regularly, monthly, and you have a treatment plan for that, and that's expected, and it's lasting the normal amount, any unusual bleeding needs to be reported. I'm super surprised when people don't understand that. And sometimes patients come to me and it's 3 months down the road. They're coming for a follow-up to get a refill or to get a pellet insertion. And they start with, oh yeah, I've been bleeding for 3 months. It's just a period. And I'm like, well, you're not supposed to have a period. You're using progesterone daily. And you said you did not want a period. So please be aware that any bleeding that's not scheduled, planned, or expected is abnormal, and that information needs to be shared with your doctor. So as a bio-T trained physician, I was extremely surprised to learn during the presentation on the subject of how to deal with vaginal bleeding that while using estrogen replacement therapy in the form of pellets, most bio-T trained doctors are trained to use and recommend only daily progesterone. There was zero mention of the possibility of using cyclic progesterone other than simply just giving anybody daily progesterone. Now, I know I'm not the only doctor that recommends cyclic progesterone instead of daily progesterone. So I was just surprised that along with 100 other people in the room, nobody raised that issue or that question. Now, I have almost 10 years of experience using pellet therapy before joining the BioT, let's call it movement or organization. So I decided to ask my BioT rep, who's very knowledgeable overall and has been extremely helpful during the transition to BioT, why there was no discussion about allowing a period. And her response was very interesting. Using daily progesterone is easy, and it will highlight as outliers all the patients that are experiencing any vaginal bleeding, and they will need further workup and possibly referrals for OBGYN consultations. There were very few OBGYNs in that room. The majority of doctors or providers who were there training for BioT were either family practice or internal medicine doctors, a few other specialties. Apparently, using daily progesterone does not require additional in-depth understanding of the inner workings of hormone balance. It is a very, very simple type of therapy and easy to provide instructions for post-care. Please take this pill daily. Don't stop. It's also something very easy to remember. Take a pill daily. Mark your calendar. Set a reminder. It's much more complicated to tell someone, hey, you got to start taking the progesterone the first of each month. Take it for 10 days and then stop. And remember to do it again the next month. And if your bleeding starts before you take the progesterone, that's a problem. You got to call me. And if your bleeding is more than 5 days or 7 days, or if it's heavy, you got to call me. That's not normal. It's very simple. You just tell everybody, take the progesterone daily. If you bleed, call me. Now, because I'm an OBGYN and I'm comfortable doing the workup for any possible side effects that occur from the use of estrogen in any form, including pellet therapy, I don't really have to worry about sending patients for an ultrasound or referring them to another doctor. However, that is not the case with the majority of doctors who use pellet therapy. The majority of doctors who use pellet therapy or estrogen, who are not OBGYNs, worry about vaginal bleeding. They don't understand the mechanism of vaginal bleeding, and they fear vaginal bleeding. And they instill this fear of vaginal bleeding into their patients as well. Now, I'm not a hormone expert, but I do have expertise and multiple additional training certifications in hormone replacement therapy, as opposed to the majority of OBGYNs out there. It just seems easier for me as an OBGYN to understand how much estrogen and how much progesterone and how much testosterone a woman needs, because I will take into account her pre-existing female genital pathology, and I can make a much better assessment of her needs than, let's say, a rheumatologist, a cardiologist, an internal medicine doctor, a family practice doctor. Now, I personally think that OBGYNs are uniquely positioned to better understand women's needs and to skillfully navigate this maze of hormone replacement therapy pathways, because we are so familiar with the female pathology, and we definitely understand, or should understand, the inner workings and the correlation of the delicate hormone balance on a woman's body and her mental health. We are also uniquely positioned to be able to deal with any possible side effects that arise from the possible use of hormone replacement therapy. And unfortunately, that's not the case when the hormone replacement therapy is administered by a naturopathic practitioner, a nurse practitioner, a rheumatologist, a cardiologist, a family practice doctor, an emergency medicine doctor, or any other medical specialty. Now, I do think pellet hormone therapy is easy. It's just a simple procedure. Now, there's an art to the rest of it, like managing dosing and managing side effects and other things. But as a hormone replacement therapy is really a no-brainer. It should be a standard of care as far as being the best form of hormone replacement therapy, because it's so effective and likely much safer than any other hormone replacement therapy out there. And there probably aren't enough OBGYNs to service all the women that exist in the United States that would require pellet therapy. That means that many other doctors will have to learn how to use this therapy safely and effectively. Now, again, this ties a little bit into my previous episode where I talked about how to choose your doctor for using hormone replacement therapy. Please be aware that when you decide to start hormone replacement therapy, you have a responsibility to follow through. and to make sure that the type of hormone replacement therapy you chose is safe for you. And I do advise you, if you suffer from any type of female pathology, like fibroids or endometriosis, or have had an endometrial ablation, to consider seeking an OBGYN to manage your hormones rather than going to a doctor that's a rheumatologist, a cardiologist, an internal medicine doctor, or a family practice doctor. You will have special needs. You will need that trusted specialist that can manage possible consequences of using estrogen therapy when you have pre-existing pathology. But as we all know, and as I have discussed in my previous episodes, there is a serious lack of understanding regarding bioidentical hormone replacement therapy and a very serious lack of training within the OBGYN ranks. So it's very likely and not at all uncommon for such a patient to come to the OBGYN doctor for a consult and to deal with the bleeding from bioidentical pellets or bioidentical creams. And then they report back to the physician who administers the therapy that the OBGYNs told them the hormones are bad, they shouldn't use them anymore. I'm not going to get into this, but that is wrong and that's misinformation. And that's why the patient's faith in the medical system is undermined. And I believe that if a doctor believes some other doctor is doing something wrong, they should really pick up the phone and say, hey, we both see this patient. Why are you doing this? Can you please make me understand? I care about the patient. I'd like to know what can we do together to ensure an optimal outcome and make whatever therapy you give in this patient safe for them. That doesn't really happen. And we don't have time for that, which is sad. So to end this little detour, I discussed the subject of perception and how having a period is perceived not just by the patient herself, but also by the medical community that will take care of you. You being the customer, you should understand there are limitations of training and experience that your doctor might have. So you will need to see another doctor for a side effect or a complication of the hormone replacement therapy. And please understand that each physician will likely have a slightly different perception on this hormone issue and whether or not you should have a period after menopause. I'd like to end this episode with a quick recap. I talked about bleeding on hormone replacement therapy, and I talked about the concerns of what it means if you actually have bleeding while you're on hormones. I talked about client perception, the woman who's receiving the hormone replacement therapy, versus doctor perception. And what I'd like to end with is that I prefer that you, the client, the patient, clearly understands if you need to bleed, why you might need to bleed. I want you to understand when you make the decision, okay, I'm going to take daily progesterone, I'm going to take progesterone 10 days a month. I want you to understand why it is useful to bleed and that there are significant benefits to having a period every month, even decades after menopause. So I'll come back to this and discuss it more in the next episode, as I will continue this discussion next week on why it would actually be extremely useful to have a period after menopause and how that can provide significant benefits for your health as a woman. I will end here and I will see you soon. If you liked the information you heard and you'd like to hear more, please subscribe and follow my podcast. Should you find the content helpful to not just you, but possibly others, please share it and feel free to leave us a review. You are welcome to join the Facebook group, The Warrior Optimizing Wellness MD. I certainly hope that you've heard many things in this podcast that made you go, wow, I did not know that, or wow, I'd like to know more. So keep listening and I'll keep talking.